Hi guys, I know a couple of you are struggling with the endocrine system. I'm going to try and, bring it down to basics, try and simplify it a little bit, and hopefully it'll make a little bit more sense. So, let's start with thyroid disorders. So, we start with our hypothalamus, which is going to secrete a hormone to the pituitary gland. The pituitary gland is, in this case, going to be secreting a hormone called TSH, thyroid stimulating hormone. The TSH, what it's going to do is it's going to tell our thyroid gland to start producing thyroid hormones. And then what we're talking about when we're talking about thyroid hormones are T3 and T4. So we have T3 and T4. Now, what happens when we get elevated levels of T3 and T4 is we have a negative feedback system which tells our hypothalamus and our pituitary to stop producing TSH. So what will happen is when we stop producing TSH, the thyroid will stop producing T3 and T4, and the levels of thyroid hormone in our system will decrease. When they decrease and there's not enough of them, what will happen is there will be a signal to the hypothalamus and the pituitary to increase production of TSH, which will then increase the production of T3 and T4. Makes sense. So it's a negative feedback system. All right. The other thing that the thyroid hormone produces is calcitonin. And what calcitonin does is it takes, let's say, here's a bone. And here's your bloodstream. Okay? What calcitonin is going to do is it is going to take calcium from the bloodstream and bring it into the bone. Okay? So, if your calcium levels are really, really high in your blood, calcitonin is going to kick in. It's going to bring that calcium from your blood into your bone, and it's going to decrease your serum calcium levels. And just for reference, your normal serum calcium, you want it to be between 8.8 to 10.2. That is your normal calcium level. Now, there's also something called the parathyroid. And so we'll put that over here. So we have our parathyroid. Now, the parathyroids are located on the thyroid gland. They're little glands that are located on top of the thyroid gland. And the function of the parathyroid is to secrete a hormone called parathormone. Now, parathormone basically does the opposite of what calcitonin does. So calcitonin, again, is going to be bringing calcium from the blood into the bone. Parathormone is going to be bringing calcium from the bones and intestines and bringing it into the blood. So parathormone is going to increase our serum calcium levels. If our serum calcium levels drop below 8.8, your body's going to start telling the parathyroid to secrete parathormone to increase your calcium levels. All right. Now, some of the issues that we can have with this whole system. First, we have hyperthyroidism. Hyperthyroidism is basically when you have too much production of these thyroid hormones, T3 and T4. Okay? So too much T3 and T4. There's a couple reasons why this is caused. One is Graves' disease, like we talked about in class. One is thyroiditis, which is just inflammation of the thyroid, and you can also have excess ingestion of the thyroid hormones, like, for example, Synthroid, which we'll talk about in a second. So those three things can cause hyperthyroidism. So let's think about what's happening. So T3 and T4 are in charge of influencing the metabolic rate. When you have increased levels of T3 and T4, your metabolic rate goes up. So when you have hyperthyroidism, meaning that you have too much T3 and T4 being produced, then you're going to have symptoms like nervousness, you're going to be irritable, you're going to get really flushed, pink skin. Your appetite's going to increase, but no matter how much you eat, you're going to keep losing weight because your body's using it. There's a really fast metabolism. Your elevated BP, because again, your metabolism's skyrocketing, so your BP is going to be up. And you're also going to have some cardiac effects like tachycardia. It might lead to heart failure. You might have some palpitations. So those are your basic symptoms. Then you can even have what's called a thyroid storm, which means that you have way too much thyroid hormones occurring, and this can be brought on by stress, surgery, anything that's going to increase the stress in your body can cause a thyroid storm. And the major side effects that are going to happen with a thyroid storm are cardiac dysrhythmias, tachycardia, fever, and neurologic impairment. And we will come back to that in a second. So the way we know that someone has hyperthyroidism is because they will have a decreased TSH level. Okay, so that's one of the ways. And this makes sense, right? Because if you have high T3 and T4, it's this negative feedback system telling your hypothalamus and pituitary to stop secreting TSH. So we don't want to secrete any more TSH. Your TSH level is going to be super duper low. Alright, so that's one thing. Another thing that you can be able to test for is increased T4. And like I said, basically that's what hyperthyroidism is. It's too much thyroid hormones, T4. Okay. You might see that the thyroid gland is enlarged, and this is because your thyroid's working really hard. It's working. It's trying to push out these T3 and T4 hormones, and it's working too hard, so it's hypertrophying. It's enlarging. Yep. Yeah, it's getting bigger. So, you might ask yourself, how do we treat hyperthyroidism? And there's a couple of ways. The most common way and the most preferable way is to use something called radioisotope 131, which is going to radiate the thyroid and destroy the thyroid cells. So you're not going to secrete any more T3 and T4. Another way, and by the way, you don't want to use that radioisotope 131 in women who are within their childbearing years. So, because it can affect the fetus. The next thing that they might be able to do is called an anti-thyroid medication. And basically what this does is it blocks the use of iodine to create the thyroid hormone. So how does your body uses iodine iodine's like the building blocks of T3 and T4. So basically what these anti-thyroid medications are doing is it's stopping that process where they're building iodine into T3 and T4. So we're stopping the production of the thyroid hormones. And one of the medications which is used for these anti-thyroid medications is called PTU. And it is the treatment of choice for pregnant women. So that's the biggest thing you want to think about there. And then, of course, there is, With that PTU and the other anti-thyroid medications, it could take several weeks for them to come into effect. So that's something to consider and maybe teach your patients before they make their options. With hyperthyroidism, they may decide to do a thyroidectomy, which means they're going to remove the thyroid. So what's this going to do? When you remove the thyroid, there's no more thyroid to make the T3 and T4. Some complications with all of these is you could cause hypothyroidism. So we have hyperthyroidism, but if we destroy the thyroid with radiation or we remove it with surgery, you're not going to have any more thyroid production. So we're going to have hypothyroidism, which we're about to talk about, which means there's no or not enough production of T3 and T4. Okay. What can we do as nurses for patients who have hyperthyroidism? We can tell them to eat a high-calorie diet, because remember, they're losing weight. They're burning off all those calories without trying. You want them to stay away from highly seasoned foods or stimulants, because once again, our metabolic rate is already high. We don't want to increase it anymore. These patients are going to be hot all the time, and we want to keep them in a cool environment, once again, to try and keep that metabolic rate low. And of course, because we're going to see heart problems, we're going to have a high metabolic rate. We want to focus on watching the EKG changes and get their oxygen saturation, just so we know they're not going to become hypoxic. Okay. So those are our major things for hyperthyroidism. So then we have hypothyroidism, which means, like I said before, we have a decreased level of these thyroid hormones. There are a couple of things that can cause it. There's Hashimoto's disease, which is just an autoimmune attack of the thyroid gland. All right, so an autoimmune attack of the thyroid gland. But you can have primary hyperthyroidism, which means there's a problem with the thyroid. Now, whatever it is, there's a problem with the thyroid. You can have also what's called central hypothyroidism, which means there's a problem with either the hypothalamus or the pituitary gland, where there's not getting that TSH stimulation, and then, of course, then the thyroid's not going to be producing any T3 or T4. Okay. So some symptoms that we are going to see with hypothyroidism, and let's remind ourselves that without T3 and T4, the metabolic rate is going to plummet. So with that in mind, let's talk about some of the symptoms. There will be extreme fatigue, hair loss, brittle nails, tingling in the fingertips, some hoarseness, and some mental disturbances. Okay? And then if hypothyroidism becomes severe enough, you'll get what's called mixed edema, which just really means severe hypothyroidism. And some things that go along with severe hypothyroidism are a mask-like expression, puffy eyelids, loss of eyebrow hair, thick lips, broad tongue, decreased body temperature, because remember that metabolic rate is going to be lower, decreased pulse rate. They might have an apathetic attitude, speech is slow, just think everything's slowing down, everything's decreasing because our metabolic rate is decreasing as well. And when we're diagnosing hypothyroidism, it's going to be much the opposite of hyperthyroidism. So we talked about how in hyperthyroidism there will be a decrease in TSH levels, right? Well, in hypothyroidism, there's going to be an increase, because if there's no T3 and T4 hormones, the body's sending a signal to the hypothalamus and the pituitary gland to make more T3 and T4, which means we need TSH to be secreted. And also, we're obviously going to see a decrease in the free T4 hormone. There's only one real medication that they use to treat hypothyroidism, and that's Synthroid, and it's basically a thyroid hormone replacement. And one thing you want to think about when you're teaching your patient about Synthroid is you don't want to stop it immediately. You have to wean yourself off of Synthroid, so be careful with that. Some other considerations that we want to think about with these hypothyroid patients is that we don't want to administer them too much fluid. Their metabolic rate is very low. They aren't processing everything as quickly. They can easily become, have fluid toxicity. You can overload them, cause CHF. And another thing you want to think about is when we're administering medications, they should really be on a dose that's lower than what you and I might take a medication dose with, someone with a normal functioning thyroid, because they're not able to metabolize the medications as quickly as we can. So they may be prescribed medications at half to a third of their normal dose. The other thing we might want to teach them is to have a high fiber diet. Like I said, everything's slowed down. They might become constipated. They might have problems digesting, so high fiber diet will help with that. And we want to have low calories because these people are going to be gaining weight because of their low metabolic rate. So they don't need as much calories. And, a low calorie diet. Okay, so let's move on to our parathyroid. So like I talked about earlier, parathyroid produces parathormone. When you have hyperparathyroidism, what that means is that your parathormone levels are high. So we talked about the parathormone and what it does. And remember that the parathormone is bringing calcium from the bone into the blood. So if you have hyperparathyroidism, you're going to have too much calcium being brought from the bone and being put into the blood. You're going to have hypercalcemia, increased serum levels of calcium. Now, so all of our symptoms that are going to go along with hyperparathyroidism are going to involve that increased calcium level. So everything's due to too much calcium. And so we have, there's two really big symptoms that you want to think about for this. There is formation of kidney stones, because remember we talked about in class how too much calcium can cause those calcium stones. So that's one thing you might see in these patients. And the other thing you might see is the decreased excitation of the nerves. So when you have high calcium levels, that's going to cause your nerves to work slower. Everything's going to slow down. It's going to cause muscle weakness. It might cause heart problems, because remember your heart is a muscle. It's going to cardiac dysrhythmias. You might have bone pain. Just think about it. You're bringing all this calcium out of your bone, bringing it into your blood. Some other things, nausea and vomiting, fatigue, with those high calcium levels, hypertension, irritability, peptic ulcers, and pancreatitis. So, some things that they can do for hyperparathyroidism is they can do some phosphate therapy. Because if you remember what phosphate does, it is the levels of phosphate in your body are indirectly proportional to your calcium levels. So if you increase your phosphate levels in the body, you will decrease your calcium levels. You can give them calcitonin. So we already talked about calcitonin, which is secreted by the thyroid, but you can also give calcitonin as a medication. And what calcitonin does again is it just brings calcium from the blood into the bone. So if you have hyperparathyroidism and it keeps bringing calcium into the blood, calcitonin is going to help fight that effect. You might be able to bring your patient to dialysis, getting your patient more active, getting them mobile, ambulating, because remember when we talked about osteoporosis, when you put stress on your bones, it causes your bones to retain that calcium because they need them for that strength. So that's an option. And then, of course, we're thinking diet-wise, we don't want them to have excess calcium. So we can teach them that. One of the things that we can do surgically to fix hyperparathyroidism is to remove those parathyroids. So it's called a parathyroidectomy. And one thing that we really want to look for after we remove those parathyroids is called tetany. Tetany is basically the overexcitation of your muscles and your nerves because of hypocalcemia. If we're removing those parathyroid glands, we have no more parathormone being produced. And parathormone was in charge of bringing calcium into the blood. So without that, there's no more parathormone to bring calcium into the blood. Our serum calcium levels are going to plummet. So we want to look for our early sign of tetany, hypocalcemia and tetany. And we'll talk about ways to look for that when we talk about hypoparathyroidism. Then, some other things that we want to be concerned about after a parathyroidectomy is just our airway. Think about it. If we're right here in this thyroid area, we want to think about our airway patency, and we want to make sure they stay hydrated. Alright, so our last thing for the thyroid is hypoparathyroidism. So, as I said before, hyperparathyroidism causes increased parathormone. So hypoparathyroidism is going to cause decreased parathormone. So we can expect for our blood calcium to be what? Decreased. Decreased because we don't have that parathormone being produced to bring the calcium into the blood. And all of our symptoms are going to be involved with this decreased calcium level. So we're going to have decreased calcium. We are going to have that tetany that we just talked about, that overexcitation of the nerves and the muscles. You might be irritable, anxious. You might have some bronchospasms, some laryngeal spasms, the carpospasms, photophobia, so you might be really sensitive to light, just all due to that overexcitation of our nerves. And also seizures, which makes sense if your seizures are just nerves going crazy. They're excitation of those nerves. So it makes sense that if you have overexcitation of your nerves, tetany, seizures make sense. Some ways to check to see if your patient's having tetany. One of the older ways that they used to do it is called Trousseau's sign. So what they would do is they would put a blood pressure cuff on your arm and start seeing if you were going to have these carpopedal spasms, or they might put it on your leg and see if you're having spasms. And that might be an indication that your patient has tetany. They don't really use that so much anymore. Now they use I don't know how to pronounce this, Chavokstik's sign. I can't read. So basically what you're going to be doing is you're going to be tapping your face, and over facial nerves and see if there's any twitching of the mouth, eyes, or nose. And if there is, that might mean that you are hypocalcemic, and that you are experiencing tetany. So some things that we're going to do for these patients, and like I said, a lot of these patients that are hypoparathyroidism, who have hypoparathyroidism, are post-parathyroidectomy, okay? So we just took their parathyroid, they have a decreased calcium level now. So these are some nursing considerations that we want to think about with these patients. We want to have IV calcium gluconate at the bedside. And basically, you're giving them calcium so that they will stop experiencing these seizures, stop experiencing the tetany, and it's almost immediate. So you want to have that at the bedside just in case they start having adverse reactions to the procedure. you want to give them parenteral parathyroid hormones so that you can keep the blood calcium high. And you also want to think about their diet. So unlike your hyperparathyroidism patients, you want to have a high calcium diet. You want to have a low phosphorus diet because remember they have an inverse relationship. You might think that foods like milk and eggs are really high in calcium, so they're good, let's eat them. No, that's not true because these foods also have high phosphorus levels, so they kind of nix each other out there. So we want to stay away from milk and eggs. They're not really going to help. What we do want is to give oral calcium supplements. That makes sense. We want to give aluminum supplements because aluminum binds to phosphorus, so it's going to decrease the phosphorus levels and increase the calcium levels. And we want to also give vitamin D. Some of the nursing interventions we want to think about for these patients, remember they're having overexcitation of their nerves, they're a little bit irritable. We want to have a noise-free environment for these people. We want no bright lights because remember they have that photophobia. We want to teach them to stick to their high calcium diet, to stick to all those supplements that we just talked about. And like I said before, we want to keep the calcium gluconate at the bedside just in case they start experiencing tetany, seizures, anything that goes along with hypocalcemia. Anyway, our next video will talk about adrenal problems, and I'll be right back.